Diagnostic static evaluations. Diagnostic static evaluations will include the following: weight bearing under the calcaneus, weight bearing under the hallux, open chain evaluation, and closed chain evaluation. Weight bearing under the calcaneus. Why is it important to evaluate the calcaneus? The calcaneus, or the heel bone, is the base of support of the foot, and if it is not aligned, it has the potential to impact the alignment of the structures of the foot. It is also the base of support of the ankle joint and can influence pathology at the ankle. Its position will affect the forces acting up the kinetic chain and influence knee and hip pathology. And because it is an attachment of the Achilles tendon, it can be a player in pathology of this tendon. To evaluate the calcaneus, you should know the following. The weight should be equally distributed between the medial and lateral calcaneus, with 50% of the weight on the medial side and 50% on the lateral side. Also note that the calcaneus is the base of support of the foot and the first articulation with the floor in walking, and therefore it should always be evaluated. In order to test weight bearing into the calcaneus, you can take 2 pieces of cardboard paper or 2 pieces of a towel and place it under either side of the calcaneus and then pull. What you will do is you will divide the calcaneus by 50% and go about 1 inch deep toward the toes to place your towel or paper in the correct position. The second thing you can do is look at the wear in patients' shoes, provided that these are older shoes and do have wear and tear on them. As you will note, in most cases, there will be increased wear on one side versus the other, and this could help clue you in on the weight-bearing position of the calcaneus. To set the patient up properly for this evaluation, you will take 2 pieces of thick paper or cardboard, and you will split the calcaneus in half, placing 1 piece under the medial side of the calcaneus and 1 piece under the lateral side of the calcaneus, about 1 inch deep from heel to toe. In this example, you can see how the paper is aligned with 50% on the medial side, 50% on the lateral side, and the therapist is ready to evaluate this patient. She will just go ahead and pull the paper equally and see that the lateral border on this patient comes out more quickly, and therefore the patient is bearing more weight on the medial border of his calcaneus. Here is an example of someone who presents with normal weight bearing between the medial and lateral sides of their foot, utilizing a towel that could be found in any clinic. Watch as the therapist pulls and they are unable to pull out either side, indicating equal weight bearing between right and left, no matter how hard they pull. Here's an example of looking at the wear underneath a person's shoes. When we're looking at these shoes, there's better distribution on the left foot. There's increased weight bearing a little bit laterally, but you can see there's medial weight bearing and there's wear along the bottom of the shoe with a little bit more on the lateral side, but good equal weight bearing throughout. Whereas on the right shoe, there's unequal weight bearing. There's an increase of the wear on the lateral border, not so much posterior. Look at all of these dots that don't have wear on it versus this foot, which does have wear. And the weight bearing doesn't extend as much up through the heel. So the foot that has better force absorption is actually the left foot versus the right. So again, you can notice where a patient is weight bearing and how much absorption they're getting through their full heel when you look at the bottom of a worn out pair of shoes. We will now evaluate weight bearing into the hallux. It is important to weight bear into the hallux as it is the primary toe for balance, and it is an integral part of the push-off phase of gait. To evaluate the weight bearing through the hallux, you want to evaluate the weight bearing through the entire big toe. That means the medial side, the lateral side, the distal part, and the proximal part. 50% of the weight should go through the big toe and the other 50% of the weight through the 4 lateral toes for balance. Again, the hallux is an integral part of both push-off and balance. Once you have addressed the weight bearing of the hallux, place the hallux into neutral and appropriate weight bearing of the bottom of the hallux onto the floor. And note that this may require a derotation of the toe or movement of the hallux medially or laterally. When you do this, feel for resistance and address any compensations or restrictions that will occur up the kinetic chain as a result of you putting the toe into neutral. We will now observe weight bearing into the hallux evaluated by the therapist on the patient's left hallux. The therapist will take their finger and place it under the medial and lateral side of the hallux, as well as getting a general sense of the weight bearing into this left hallux. As the therapist lifts up, you will notice that there will be an increased ability to lift that hallux up on the lateral side of the hallux versus the medial. Watch as she goes. Lifting up, little bit resistance, and not much resistance on the left. Now the therapist will evaluate the right hallux on the medial and lateral sides of this hallux. As the therapist lifts up, you can see that there is less weight bearing into the right hallux versus the left hallux. Watch as the therapist addresses first the lateral side and then the medial side of the right hallux. As you can observe from looking at this patient's foot, and it was what we found with the range of motion of or weight bearing of the hallux, is that this patient weight bears less on this big toe versus his left big toe. If you remember, this patient did not have single leg balance on the right, and if you look at the position of his ankle and his lower leg, all of his weight bearing is lateral, and it looks like he's digging into the floor with these 3 other toes to compensate for weight bearing into the hallux. Open chain evaluation. What open chain evaluation allows the therapist to observe is the patient physically able to get their foot articulating with the floor without any compensations up the kinetic chain? When we observe patients, we rarely see that a part of their foot is off the floor. The body will compensate with hyperextension of the knee or anterior innominate rotation or forward head posture to get that foot weight bearing onto the floor and ideally over the big toe. It is one of the balance strategies that we as human beings have. So open chain evaluation will allow the therapist to see the compensations that need to occur up the kinetic chain in order to get the foot on the floor. For this evaluation, the patient must be placed in a non-weight bearing position, and the therapist will manipulate the foot passively to act as if the therapist's hand was the floor and observe up the kinetic chain what that patient has to do in order to get their foot on the floor. When you're placing your patient into non-weight bearing, you should consider safety as the primary reason for your positioning. You also need to be aware that if the patient is on a treatment table in prone or supine, that the table itself might interfere with the movement up the kinetic chain. So ideally, you would take the patient's leg and bring it off the table while they are either in supine or prone. Standing with one foot off a step is most functional, and the therapist can get underneath the patient and observe what happens up the kinetic chain as they place that foot into neutral. When the therapist is beginning this evaluation, they will take the foot, putting it into neutral, beginning at the toes to determine the foot's ability to articulate with the ground. Is the foot able to get onto the floor without having compensations up the kinetic chain? Common compensations that we will see will be external rotation of the lower leg, the tibia and fibula, or even rotation up at the femur. That is why many people will walk with a toe out position. Other Compensations will be hyperextension of the knee to compensate for dorsiflexion. And those are going to be the two primary ones that the therapist will tend to see. Again, this is passive range of motion, so the therapist will note when they feel resistance in the system, when they observe a compensation up the kinetic chain, and when the patient articulates that they feel that the motion is difficult to perform or unnatural when the therapist places them into passive range of motion. Here you'll notice that the patient is in prone, and the therapist has taken their right foot and will adjust it into the neutral position in order to also place the foot and see how it articulates on the floor. A couple of things that you can note already is look at how internally rotated that upper femur is, that you can almost see the knee on the medial aspect of his leg, and he's got a genuvarum of the lower leg as well. Secondly, you'll notice that the foot is kind of tilted where you see more of the fifth metatarsal than you do the first, indicating increased weight bearing on the outside of the foot. Watch as the therapist moves the patient into neutral, what goes on at the upper lower leg, and particularly the femur. Here the therapist will rotate them and note the compensation that occurs all the way up the kinetic chain by the inability of these bones of the foot to move independently. See the compensations up the kinetic chain. This would be a good reason why a patient would have knee problems, as the patient has to compensate with the knee joint in order to get the foot to articulate with the floor properly. Again, another view from above, looking down on the same patient on the right foot and noting what needs to happen to get his foot into neutral up the kinetic chain, what compensations have to occur. Watch as the therapist moves the foot into neutral, again up at the knee and up at the femur, what goes on there. So be aware that the therapist will not only have to address what is going on at the foot, but also need to address the compensation that's occurring at the knee. Both of these areas will need to be treated with release work because we are evaluating again using passive range of motion, which will demonstrate to us structural dysfunctions, not non-structural dysfunctions. Closed chain evaluation. When we're working with the foot in the closed chain, we can also figure out why a person might be assuming the structure that they are in their lower leg. So along with the open chain evaluation, we can look at the closed chain, note the differences, and determine what is the driver of the malalignment in the lower extremity, the foot, the ankle, and the toes. To evaluate using the closed chain evaluation, you are going to place the abnormally aligned structures into neutral and observe the compensations and restrictions going up and down the kinetic chain depending on your starting point. Again, remember that you will look for compensations, feel for restrictions in motions, and also communicate with your patients to have them let you know at what point the movement of the structures passively makes them feel uncomfortable or difficult to perform. This technique is very effective when looking at a pronated foot. Remember, the human body will compensate the alignment of the lower extremity in any way possible to get weight bearing into the hallux for balance purposes. And compensations will include the following. The navicular may drop, there might be a lateral deviation of the calcaneus, a rotation of the lower leg, or a medial deviation of the talus. Any one of these could occur, or multiple factors that have been mentioned can also occur together in order to bring that hallux onto the floor. When we're using the closed chain evaluation, we can address each of those issues and see what happens, and usually the medial portion of the foot will come off the floor, and we will now have an understanding why the body has assumed the alignment that it has. It is important to notice that we need to not only address the compensations that are occurring to get the hallux onto the floor, but also address the structures that are not being able to get onto the floor themselves. Otherwise, we will not have carryover with our patient with regard to a pronated foot or any other type of alignment issue with our patient. Here is an example of a compensation at the femur to get the first metatarsophalangeal joint on the floor. Watch what happens when the femur is placed into neutral alignment. Look what happens at the medial aspect of the foot. As he's placed into neutral, that entire foot comes off the ground. So the femur is rotated internally to compensate for the inability of the first metatarsophalangeal joint to articulate with the floor. Let's watch it again. Foot goes into neutral, big toe comes completely off the ground. As I had mentioned earlier, I believe that this is one of the innate senses of the human body, in addition to keeping the eyes on the horizon. Both are going to be important for balance and proprioception. And the body will compensate in any way possible to get the big toe on the floor and keep the eyes on the horizon, as we see in scoliosis patients. Here's an example of a pronated foot, and you will note that the foot is pronated by the talus being pushed medially. So what the therapist will do is to align the talus where it should be and notice the compensation that occurs at the arch of the foot. Watch as the therapist adjusts the talus into the appropriate position. Here is that medial talus sticking out. You will note that there's not a lot of definition between the medial malleoli and the bottom of the foot. When the therapist places that foot or that talus into neutral, you see how the entire heel and the first metatarsal come off of the floor. So this patient is compensating with a medial talus in order to get the medial portion of his heel as well as the first metatarsal and the toe onto the floor. The therapist now will palpate for the restriction in the tissues. Again, this is going to be a structural dysfunction because it has been noted with passive range of motion. Once the therapist finds the dysfunctional tissue, and the therapist has found it, indicated by her thumb, they will now address it with treatment, which will be the release of that restricted tissue in order to get carryover of this compensation that is occurring at the talus. So be aware that a patient who is treated with orthotics or taping or some other type of treatment, maybe just of the talus, it will never have carryover because the body will always compensate to put this medial heel and the arch as well as the first metatarsal onto the floor. So you will never get a resolution to this abnormal alignment until you address the underlying reason that the patient is doing it. And the open and closed chain evaluations will allow a therapist to determine why a patient is presenting with the alignment that they are presenting. Here's some final thoughts on the closed chain evaluation. Closed chain evaluations are used when there is pain in weight bearing without pain in motion. It's also used to improve alignment in order to regain carryover from treatment, to improve single leg balance when the reason for a lack of balance is an alignment problem, and also to address foot deformities such as the pronated foot, hammer toes, and bunions. When performing the closed chain evaluation, you will understand why the patient has adapted these types of deformities. It is important to remember that when you're performing the closed chain evaluation and the diagnostic static evaluations, you will need to address not only the compensation, but also, and more importantly, the underlying reason for that compensation. In the case of a pronated foot, compensations are occurring in order to get the big toe on the floor. You will need to make sure that you provide motion to those structures so that the hallux can then get on the floor without having to adapt using compensations up the kinetic chain. Otherwise, you will never have carryover and the patient will always have an alignment problem in their foot and ankle.